Hello. So we are going into the home stretch and we're going to talk about our upper extremity impairments that we could have. We're going to focus on the shoulder and the elbow. We have a few presentations that are set for this week, and I'm only going to be talking about the ones that are not covered in the presentations. The wrist with carpal tunnel is being done by Marcy, so we're not including the wrist in this one because you will be watching her presentation. All right, so we take a look at the glenohumeral joint. As far as the type of joint it is a ball and socket, but it's like doesn't have much of a socket. Remember that? Because when we look at the congruency, it really doesn't have very much congruency between that head of the humerus and the glenoid cavity. As far as our joint by joint approach is whether we're looking at stability or if we're looking at building stability or building mobility. And we really are trying to build more stability within the shoulder. It is quite a mobile joint, and we need to make sure that we're not causing any issues and damage to it by adding more stability to it. As far as movements go, you guys know flexion, extension, abduction, adduction, and then put them all together to make circumduction with our internal and external rotation as well. So what makes up that ball and socket? We're looking at the humeral head and the glenoid cavity, but only about 25% of the humeral head is covered by the glenoid cavity. So we've got this added addition of a labrum that can extend that glenoid cavity to give it slightly more of a socket. And then we've got some ligaments that are surrounding it as well. We've got the glenohumeral ligament, and then in general, making up the whole shoulder, we also have our coracoacromial, the acromioclavicular. We've got just so many different ligaments in this area. And then on top of that, we have the rotator cuff muscles. And really, when we look at it, these are what is giving the stability to the joint itself. Yes, it has ligaments. Yes, there is the labrum, but really the bulk of the stability comes from the rotator cuff muscles. Now, I have an interesting picture, and we looked at this in anatomy as well, where we have our supraspinatus tendon that you can see on the top, and then you have the infraspinatus and the teres minor that you see on the posterior side, with the subscapularis that you can see on the anterior side. And those are our four rotator cuff muscles. Now, some issues that we can sometimes have with those would be like a shoulder impingement. And usually the impingement is it's affected when we are doing abduction. And it tends to happen in the location of the supraspinatus muscle and the bursa that is also located right there. So usually it's under 35 years of age, and because of sports or jobs with a lot of overhead movement. If you remember when we were talking in anatomy, that dental hygienists are actually one of the most prone to shoulder impingements because of them sitting down and needing to lift their arm up to be able to clean the teeth and be able to have a good spot to be able to see and yet still function. And so typically when it's under 35 years of age, it's usually due to like job related issues or sports. As you get older, it's typically just a degeneration injury itself. So you can see here, you have a bursa that is filled with fluid, right? And you have this subacromial space right here and the supraspinatus running through it. And what ends up happening is that over time, it can put a pinch and it starts to degrade this muscle until almost it's non-existent in that area. It's a very small space that's there. So a lot of this is trying to build up suprascapular or the supraspinatus strength and activation to be able to combat this impingement that's happening. As far as testing and to know whether our clients might have a shoulder impingement, now granted, they will need to go to a physical therapist or to a doctor to get a diagnosis. I'm just letting you know that what they usually end up doing is doing like a shoulder impingement test in which you cross your arm across your body with your hand touching your other shoulder and then lift your elbow up as far as you can. If this movement is causing pain, that's usually an indication of shoulder impingement. You can also go in and start looking at the MRI and seeing what damage is actually being done, how much swelling or inflammation there is in the supraspinatus to kind of guide how things are going. And that will all happen with the at the doctor's office or at the physical therapist's office. So as far as working with corrective exercise continuums, so what do we need to do? Well, we really would like to inhibit the stronger muscles around in that area, which tend to be the upper trapezius, the infraspinatus, and the pectoralis muscles. So inhibiting by doing self-myofascial release, doing rolling of those areas. A lot of times using like a lacrosse ball is a perfect way to do this. And you can actually put the lacrosse ball between your back and a wall and then kind of like move your body around and be able to actually dig into that infraspinatus and even like the teres minor, teres major area as well. Roll it up a little bit to do the upper trapezius. And then if you turn around, you can use the lacrosse ball on the pectoralis muscles. And I find that using a lacrosse ball against a wall gives you better myofascial release than trying anything with a foam roller. There's also things that we can do to help lengthen. So we've got the sleeper stretch, what we'll look at here. So in the sleeper stretch, you'll have the person will want to lay down onto their side, and they're on their affected side. So in this example, he would have a shoulder impingement on that left shoulder. Now roll forward just a little bit so that upper shoulder is over the bottom shoulder. And now we're just doing an internal rotation stretch. It's called the sleeper stretch because you're laying down in like a sleeping position. So holding that down, count to about 10 or so, let it relax, and then you can just repeat that several times. And I would repeat it several times and several times a day. So doing it, like 3 to 5 times until, just holding it long enough to not cause too much pain, about 10 seconds or so, then let it relax, repeat that a few times, and then do that a couple of times throughout the day as well. You can also work on shoulder mobility by taking a look at this example here of abduction mobility. So you can see that he is grabbing onto a pole, and this is if his right arm is the one that is injured or has the shoulder impingement. I'm going to keep playing this video again. He's using his good arm to push the pole up just to help get into that position of abduction. Usually somebody who has a shoulder impingement cannot do shoulder abduction to this extent without it being aided or assisted. So that's what the pole is doing, or the dowel is doing. You could use a broomstick, it could be a cane, it could be any kind of a device that's round, or it doesn't even have to be round, it could be a yardstick. Whatever the case is, you're holding onto it with your good hand, you're pushing up so that you are passively moving into the abduction. So then with activation, some of the exercises that we are going to be doing would be resisted shoulder extension and flexion. So here in this first video, we're looking at shoulder extension. You can see her elbow is tucked in tight next to her trunk of her body, and she is simply doing external rotation of the shoulder using a therapy band. This is usually the motion that is most needed of strengthening with this particular injury of a shoulder impingement. So usually that external rotation is really important. However, I would not neglect doing resisted shoulder flexion. So here in this video, you can see she's working her other shoulder, but you would just turn around to be able to use it on the same shoulder, and doing internal rotation. So again, she's got her elbow tucked in tight next to her trunk, and then it's an internal rotation of that shoulder and then back again, and then repeating these for a series of 8 to 10 of them, and repeating that a couple of times, usually about 2 to 3 sets of that. And although you do want to focus on the shoulder that is injured, it's highly suggested that you actually do these with both shoulders, just to make sure you're building stability up in both of the shoulders. Now, this guy that was using the pole previously for the mobility exercise, he's now going to do an eccentric shoulder abduction exercise. So what he's doing is he's lifting his hand up to as far as he can go with abduction. Then he uses the pole to passively move it up even higher. And then what you do is very slowly, you are abducting as slow as you can. I would slow it down even more than what he just did. And you are abducting back, or adducting back into your body. And what it's doing is it is eccentrically working abduction, which is a great exercise as far as trying to build the strength and stability, but without causing the pain in that motion of abduction. So I'm going to play it just one more time to kind of show you what we're doing. So he's lifting his arm up as far as he can go with active abduction. Then he uses the pole to move it up into and he could go higher even than that. He could go all the way up to what he was doing with the shoulder mobility, and then slowly drop that arm back into a deduction, go even slower than what he was doing, and repeat that 8 times in a couple of sets. All right, as far as integration, what we're eventually working towards is doing like single arm rows, okay? And you can do those with a variety of different, a variety of different equipment. So here up in the corner, we first had like an resistance band that pulling in there, so you can start with a really limited amount. What I would suggest is always starting with it out in front of you for a horizontal pull, and not an accentuated or inclined vertical pull. So we don't want it to be coming from above your head, because often what that ends up doing is activating the upper traps more. And so it's not activating the right muscles, and you're not building up strength in the right muscles, because usually shoulder impingement is coming through because we've been activating the upper trapezius instead of the more appropriate muscles of like our latissimus dorsi and, our teres major and such. So when we're pulling back straight from a horizontal position, as we're showing in all of the positions here, this is what the desired result is. We could do that, as I said, with the bands that we have here, resistance bands. You could also do it with cables and machine weights. And then you could also do it working up to doing it with dumbbells. But keep in mind that we do want to stress good, proper position when we're doing them, because as soon as we move to free weights, it adds in a lot more stability requirements to be able to perform that move. All right, so we talked about lower cross syndrome earlier in the week, but now let's talk about upper cross syndrome. So remember, we are flexion addicts, and what ends up happening is then we end in like shrugging of our shoulders, raising the shoulders towards the ear, tipping our head back just a little bit, an extension. And we end up having tight upper trapezius and levator scapula muscles, and tight sternocleidomastoid, which is a muscle within our neck, and the pectoralis muscles. And we tend to have weaker deep neck flexors, as well as weaker middle trapezius, lower trapezius, and the serratus anterior. So as far as what we're looking for our muscles that are overactive and underactive, overactives, as we said, are the pec major, latissimus dorsi, also the coracobrachialis, and underactive would be middle and lower trapezius and the rhomboids and the supraspinatus. And the infraspinatus often as well. So what are we going to do? Well, we want to inhibit the ones that are overactive. So inhibiting the latissimus dorsi, inhibiting the pec muscles. We talked about being able to use a lacrosse ball to be able to do the pecs, but you can also, and she's doing it on the floor. I personally like the wall just because I don't feel like putting my face into the floor all the time, but doing it on the floor does add gravity and the weight behind it, which can be nice as well. And then he's got some rolling of his latissimus dorsi here as well. Lengthening, we do want to do some good pec stretches. That would be awesome. And latissimus dorsi stretches as well to be able to lengthen those overworked muscles. And then for activation, we would like to do like a shoulder blade squeeze. So it's basically starting out like you're doing a row, but without actually using resistance to begin with. But it's the same motion, pulling those blades together, and then start working towards the resistance band rows. And you really want to focus on that contraction of the back, contraction of those rhomboids, especially to be able to pull those scapula together. That's what we're going for. You can also do the exercises of ITYWs. I'm going to show you videos of those in just a minute. Ultimately, working towards integration, you could do something like a squat to row, or in fact, doing farmer carries is a great way to integrate these muscles as well. So let's look at the scapula for just a minute. As far as a joint to joint approach, we are hoping for stability of the scapula. It kind of falls in with the shoulder. So trying to work on the stability of it. And you might be asking yourself like, well, the scapula, how can it not be stable? Well, that is what we call winging scapula. So I believe we've even looked at this with some people in anatomy and found that there were some people who do have winging scapula. You can see here it's more accentuated on her right side than on her left side, in which we just have that scapular blade that's pulling back and creating a gap right there because it's not tucked in tight next to the thoracic cavity. So the way that you do that, you can either do it on a push-up on the ground or even just up against a ledge or a wall and have them basically do a push-up motion and seeing what that back looks like. And here you can see some accentuated winging of the scapula that's here. So what's overactive? Our pectoralis major and our latissimus dorsi, as well as some deep muscles within the thoracic spine. Underactive is our serratus anterior and the middle and lower trapezius. So what are we doing? We want to inhibit the pec major, the latissimus dorsi, and some of those deep thoracic erector spinae muscles that we have. Lengthen the same way. So here's some good examples of just some pec and some latissimus dorsi type stretches that we have. This is another one that I really like, of grabbing onto the door frame and like pulling out as far as you can to give a really good stretch. As far as some activations, what we would like to do is we have scapular punches, which is sticking your arms out straight and then basically like protracting and retracting your scapula and doing it as accentuated as you can. So I'm going to show my friend John here just one more time as he's going, right? So he's pulling back and then forward. So retracting, protracting, and just activating those rhomboid muscles to be able to fire and saying like, these are the ones we're wanting to actually fire, instead of compensating with, say, other muscles like our upper trapezius and such, and latissimus dorsi. All right, then we have our IYTWs. So here, body is in the shape of an I, just straight up and down. Now it's turning into a Y. We're just contracting back, thumbs are up, and we're just doing like extension essentially in different positions. And some rotation gets involved in there. That's the T's. And then when we bend our elbows, that would be the W's. So it's just putting your body into that position onto the ground. You can also do it from a standing bent over position or standing up against the wall. Eyes again are when your hands are straight out up above your head. Remember, thumbs are always pointing out up to the sky when you're face down. Here's our Y, just by doing a little bit more of an abduction. Here's our T's going straight across, and then W's will bend our elbows and do the same motion. And it's really focusing on that back contraction of the rhomboids. So as far as integration goes, another way is to build up to a push-up plus, which is essentially doing a push-up and then pushing just that little bit further, like you were doing a scapular punch or like doing protraction, to be able to get this little hump over in your back and give it, and that's going to work. That little extra bit that you're going to do is what's working that serratus anterior as you're going through. You can also do it with a standing cable and doing like a chest press, and then go out just that little bit more by actually activating that serratus anterior by doing that little bit more that you have of that protraction that's there. All right, elbow joint, type of a joint. It is a hinge joint, right? Expected movements is we only have flexion and extension of the joint itself. It articulates with the ulna articulates with the trochlea, and the radius articulates with the capitulum, or the capitulum, depending on how you want to pronounce it. As far as muscle attachments go, so on the medial epicondyle, remember that's where all of our wrist flexors are found. So those are all our flexor muscles. And on the lateral epicondyle, that's where all of our extensors are found. So all of the wrist extensors. Now, two of the conditions that we can have are tennis elbow and golfer's elbow, and both of them are epicondylitis. Monica's presentation was on tennis elbow, so I'm just going to focus on golfer's elbow, which is affecting that medial epicondyle, and that's where you're going to feel that pain and inflammation. So with golfer's elbow, you are dealing with the medial epicondyle. The flexors are the ones that are causing the issue. And so we want to work on, and then what can activate it is doing any kind of a flexion that's against resistance. So what do we need to inhibit? The muscles that are tight, which are those flexors. So we can also stretch them by doing a stretching pose such as this, right? So just kind of doing an active or it's a passive stretch that we have, stretching out those flexor muscles. You can also put your hands onto the ground in front of you with your fingers pointing towards you, so they're backwards, and kind of like lean your body back to try and stretch it out as well. It's a great exercise, a great stretching to always start with. Then as far as activations go, we want to be working on wrist extension and finger extension. So you can do that with any kind of a weight or a resistance band when you're just holding still, like you can see right here. And then he would extend his wrist to he or she, I can't even tell, extend the wrist and then drop it back down and extend the wrist. And so you're working on that extension. You can also work on it with finger extension by putting a rubber band on the outsides of those fingers and then opening those fingers up. And that actually helps to extend a lot of the muscles of the extensors, because they do go down to the digits, like the digitorum, the mini-me, and the pollicis as well. And that's what we have as far as our upper extremities go, in combination with what Samana and Monica and Marcy all did. So this ends our week this week, and I hope you guys have an excellent weekend.